I'm going to talk about LEMS because I think that's the reason why we're here today, okay? And this is the overview of what I'm going to talk about. Now, I think I'm allotted 45 minutes, but I don't normally have about 20 slides. I don't think 20 slides will fill 45 minutes, and I think it's really open for discussion for us. If you have any questions, you want to talk about stuff, you can go ahead and interrupt me. But basically, I'm just going to introduce some basic concepts about LEMS, and first I'll talk about the neuromuscular junction because that's what's important here with this disease process. Then I'll talk about what causes LEMS. The neuromuscular junction is what I want to talk about first, and make sure everyone knows what the neuromuscular junction is. And so if you look at this, okay, so you have this nerve that's coming out of the spinal cord, and this nerve is the controlling cable of this muscle here, and it has to meet and interface and connect, okay, to that muscle. And that point right there where it attaches, and there are multiple points in this muscle, but for that particular muscle fiber that's being touched by that nerve, that's the neuromuscular junction. So there are, a bunch of neuromuscular junctions in there, okay? But this is the site where we're paying attention to with this disease, okay? And this is another cartoon, and you can see this is the spinal cord. This is a very long nerve, but this cartoon is just drawing it as a very short nerve. And it shows that there are different little fibers. These are called axons of this nerve, different little neurons. And these neurons all interface into different spots within these tiny little muscle fibers. These are very, very small muscle fibers. They're no larger than 100 microns or 100 micrometers in diameter. So there are many of these in a big muscle, like the quad. And this is what the area that we're looking at, the neuromuscular junction here. And this is not a cartoon. This is a scanning electron microscope. And this is here, the individual nerve fibers, these axons, as they kind of attach to a real muscle fiber here. You can see there's the interface. And so there are a lot of them. And this one single axon branches out to a lot of different branches, and each of them will eventually attach itself to a muscle fiber. And so that's the communication point, okay? The neuromuscular junction, if you draw it out, because we've sort of, through research, we've come to understand what the neuromuscular junction is doing. So this is that nerve fiber or branch of it. And then it reaches this point, and this is the muscle itself. This is that neuromuscular junction, that interface here. There are a couple of branches going to other muscle fibers. And this is a very complex area. The signal is coming through here, and it actually has to communicate across this gap, and this is a synapse. And so these vesicles here that look like little balls actually contain chemicals, and that chemical is what we call a neurotransmitter because it's a communicating chemical between the nerve and the muscle. And that neurotransmitter for muscles is what we call acetylcholine. So each of these little balls are waiting to be deployed out into this area, this neuromuscular junction, when it's told to go out and communicate. So these are messengers that are going across here to activate the muscle on this side. Okay, and the little messengers that are packaged in these little vesicles, these little balls, which we call vesicles, are acetylcholine. Okay, so these are what we call synaptic vesicles. So that's the communication mechanism. That's how it works. Okay, here's another cartoon that gives you a little idea of what we're talking about. Again, this is that nerve, and this is the muscle, and this is the neuromuscular junction. And when the signal comes in here, that's what one means. The signal comes across here. It activates a bunch of things, like these channels here. And I'm drawing some attention to these channels because these channels are important in LEMS. These are calcium channels, voltage-gated calcium channels. And they're important in activating these vesicles. And you saw on the previous slide those balls right here, those are the same as these little circles here that are filled with the chemical, the acetylcholine, the neurotransmitter, that's being released into the junction. And these junctions actually, these neurotransmitters come over here and they activate channels on this side. Channels are basically holes. They're well-defined proteins that create a hole that allow ions like sodium, potassium, and chloride to pass across the membrane. That's how electricity is part of this signal. It allows electrically charged ions to move across the membrane. And if they don't, then you can't get a signal. So when a signal comes along here, that's also an electrical signal that activates these calcium channels, and the calcium channels open up and tell these vesicles, okay, you can deploy. And then this chemical, this acetylcholine, comes across here and activates these channels over here. These are different channels from these, and these channels open up and allow ions to move into the muscle. And when those ions move into the muscle, then a whole bunch of things start happening. The muscles basically are able to activate and contract. Okay. So this is what's happening. This is how nerves communicate with muscles, the neuromuscular junction. Any questions? Clear? All right. I just thought I'd throw in this picture here because it's kind of a nice picture to show you that it's a rather complicated organ. This is also electron microscope, so I didn't want to just show you a bunch of cartoons. I mean, this really exists. Seeing is believing, so I decided to show you. This is what a real neuromuscular junction is. These little balls are these vesicles, okay, that are filled with the chemicals, and they're ready to be released into this gap here, okay. It's not as clean of a picture as when they draw it in the cartoon. It's kind of a three-dimensional thing that kind of goes in, and it's surrounded by the muscle. And these folds here are part of the muscle. Okay? These are the synaptic folds. So these vesicles are all ready to be released. This is a normal neuromuscular junction. Okay. So let's just kind of review that. This is the outside of the neuron, of the nerve, and this is the inside of the nerve. And when a signal comes in, that electrical signal activates and tells the voltage-gated calcium channel, that's what VGCC stands for, to open up. And when it opens up, then calcium can come into the cell. And when it comes into the cell, then the calcium can do something like tell the acetylcholine to be released out into the synapse, into that gap, and go and activate the muscle over here. Okay. So let's talk about LEMS. LEMS, as many of you have already heard, is caused by an antibody, or in some cases, an antibody we don't know, but in most cases we have identified the antibody. So this antibody is right here, I put it in here, and it's making this channel not open up as easily. So it's kind of like holding the door shut a little bit. Okay. Now the door, if you keep pushing on the door may eventually open. It's kind of get rid of the antibodies, trying to shake off the antibody a little bit. Okay, but the electrical signal will come in, and the calcium can't get in because this antibody is preventing this door from opening, preventing this channel from opening. And then unfortunately what that means is acetylcholine will not be released anymore. It's just going to stay in those little packages, those little vesicles. Okay. So going back to this picture here, these are these calcium channels I'm talking about. And then there are antibodies that are all kind of creating trouble for these channels. Okay. So what's the proof? I mean, I'm telling you this. I show you some great pictures. Is this really true? I mean, do you believe this? Yeah, of course you do, because your doctor tells you so, right? The proof that voltage-gated calcium channel antibodies can cause LEMS. Well, there's some pretty good proof, okay? If you take human blood, human serum, okay, and if you give them to mice, the mice get weak. Okay, so it seems like there is something in the human blood, and it's probably these antibodies which is doing it, okay? So that seems to prove that the antibodies that are partially prove that the human antibodies that are in the serum can actually do it, even in other animals, even in mice. Okay. You see a release of fewer synaptic vesicles with each electrical impulse. So that sounds like just like what I just told you. You can see that in the mice. Okay. And then there are rare reported cases of women who have LEMS, who are pregnant, and they give birth, and their baby actually has LEMS for a month or two. Transient. antibodies. Now, the mother is making the antibodies. The baby is not making the antibodies. So after the baby is born, the baby will have LEMS until the antibodies disappear from the baby, which will eventually happen after a month or so. Okay, but that's very compelling that, you know, it can be transferred through the blood in animals and even from mom to baby. And we see this in other diseases as well. But this I think provides some reasonable proof that blood and something that can pass through the placenta can cause LEMS. Okay. So the overall conclusion, arching conclusion, is that voltage-gated calcium channels, when we see them, are what actually cause LEMS. They are pathogenic, as doctors call it. Okay. What do LEMS patients experience? Well, I think, you know, I probably can't tell you guys any better than you guys can tell us, all right? But weakness, and in most cases when we survey them, it probably starts in the proximal legs, and that means kind of in the hip area. Trouble getting up from a chair, for instance. Kind of spreads out, spreads to the arms, and then eventually could affect the face as well as time goes on. And it usually goes from proximal to distal, so from in the legs, from the hips, and then eventually kind of spreading out into the feet, and then from the shoulders spreading out to the hands. And that's what we doctors have generally observed and heard from our patients. So patients will tell us that seems like once they get going, it's like when they've been resting for a while, it's hard to get going. But once they start moving and they get a little warmed up, you know, they start stretching out and moving the muscles, then they can actually move a bit better. And they start walking better and faster and faster. So a little bit of brief exercise improves it. Okay. The other thing is there are these things we call autonomic features, and that has to do with a different part of the nervous system. Okay. And that can affect the things that we normally associate with automatic functions, like making saliva, like going to the bathroom and stuff like that. Okay. And so a lot of the complaints that we see is sometimes there's a dry mouth because that's part of the autonomic nervous system, constipation, erectile dysfunction for men, orthostatic hypotension. That means that the blood pressure can drop significantly if you get up from, you're lying down, you get up, and you stand up, you're like, whoa, you know, a little lightheaded. Okay. So the blood pressure can drop. And that's because our body's normal mechanisms, normal methods of regulating blood pressure, of increasing the blood pressure when you get up. Because when you're lying down, your heart doesn't have to beat as hard, or your blood vessels don't have to constrict. But when you stand up, in order to make sure there's enough blood getting to your head, the heart will probably have to beat a little harder, okay, just to make sure it goes against gravity. So orthostatic hypotension is something that we've seen. They may say that patients might say that their weakness kind of fluctuates. So sometimes they're good, sometimes they're not as good, and may actually fluctuate significantly with temperature. I think sometimes patients say that they do better when it's cooler than when it's pretty hot. When it's hot, it's hard to do anything. And it's beyond what we normally would experience, patients who do not have LEMS would experience. Okay, I'm seeing some nods, so I'm saying the right thing, right? Okay. Yeah, I mean they can get dizzy when they're getting up from a lying down position or seated position sometimes. So how do doctors diagnose LEMS? Well, sometimes it's easier and sometimes it's hard. We usually say that we like to see an abnormal EMG. And when I say EMG, I mean that, you know, horrible test that we do where we shock you, right? I'm sure many of you have experienced that, right? And so in particular, we can do this thing that's called high frequency repetitive stimulation. And the idea behind this is that the channels, if they try to open, if they keep trying and trying and trying to open, they might actually eventually be able to shake off an antibody, so to speak, okay? They keep opening, and then what happens is more and more calcium comes in, and it builds up, and it could actually eventually become a stronger signal, okay? So, so if you And that's the same idea. If you exercise, you get a little bit stronger. If we repetitively stimulate, it has to be pretty high frequency, like 50 times per second, which is kind of painful. Okay, but that's one way to do it. And the other way to do it is to try to do the response, like shock, and then have the patient exercise for 10 seconds. And that's what I've done with a number of my patients. And then immediately shock afterwards, and then the response right after your exercise will be a lot stronger. Okay, that's what we call post-exercise facilitation. So when we shock a bunch of times in a row at 50 hertz, that's called high-frequency repetitive nerve stimulation. That's one way to do it. Another way to do it, alternatively, is to try exercise before and after exercise. Okay. And blood tests can also show the antibodies. 85% of LEMS patients have an antibody that we can identify. And when we see it, we believe it, and that's what the 99% means. If we see the antibody, that means we're quite sure that you have LEMS. If we don't see the antibody, that doesn't mean you don't have LEMS, because 15% of patients could potentially not have the antibody, but still have LEMS. And so that's why doing the nerve conduction study or repetitive nerve stimulation or the exercise facilitation test is kind of important, especially in those 15% of patients. This is how it might look on our EMG machine, okay? If we stimulate, I think that's 10 times, and we just sort of show, you know, first time, second time, third time, fourth time, and this is very fast. Boom, 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 right? And it gets bigger and bigger and bigger and bigger and bigger, okay? And that's that increment. That means it's getting stronger. That's the same idea as, you know, kind of getting warmed up and getting stronger as you move, right? Okay.
Which would you do first, the blood test or this shock treatment? Which is the preferred?
You know, I actually don't usually do this test. Right. I do the next test I'm about to mention. Okay. But yeah, usually I do this test because it's very easy for me to do. It takes about 2 minutes for me to do. Okay, and the blood test will take about a week for us to get it back. Okay. Okay. Yeah. So that's what we call the increment from the first response to the last response. That increase in response is an increment. So the other way of doing it is to do post-exercise facilitation. So we do the shock and see what the response is. And if it looks small, we say, well, let's just exercise for 10 seconds and let's see what happens. And then after 10 seconds of exercise, it becomes a lot bigger. And if you put them on top of each other, you can very quickly see that the small one is a lot smaller than the big one. And we can actually measure that facilitation, whether we want to divide or, you know, figure out how much that is. But that's the facilitation, this difference. Okay, this, you know, it's a shock, 10 seconds. Another shock, that's like less than 60 seconds for us to figure it out. The LEMS antibody will take us
so the blood
a week
test
or so.
Is sort of like just a validation? If going through all of this, would you do it?
Yeah, I mean, I think we would feel even, if the facilitation is very impressive, I always send the antibody, okay, regardless of, you know, if I suspect LEMS and if this is positive, I would still send the antibody, okay, because I think it's helpful for me to know if there is an antibody or not. And in the future, we might understand a little bit more about the differences between the patients who are antibody positive and negative, okay. But it's not super painful to get 2 shocks, you know, so I don't, when the patients come see me, the machine is right in front of us, so we don't have to reschedule. So it's very easy for me to do that. Normal nerve conduction study, we usually do like a bunch of different nerves, and it's a lot more painful for us to do those studies. But this one is very easy, you know, probably easier than the blood draw stick. You know.
What is the exercise you have to do?
Yeah, so if it's this muscle right here, let's say the thumb. Okay, we'll measure off the thumb and we'll shock right here at the wrist, okay, before and after. And the exercise would be to push the thumb out like this. And I provide the resistance, and you just count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and then shock immediately. I have the stimulator ready to go as soon as the patient relaxes, and I shock, and then you'll get a bigger response.
Have any of the individuals affected by this have these tests?
Yes.
Yes. Okay.
I think it sounds like everyone has. Yeah.
Everyone has had it? Okay.
Yeah. Certainly, my patients have.
Well, actually, I have one before a meeting at Burbank Hospital, St. Joseph.
Yeah.
But the result was inconclusive.
Yeah. Do you mind if I share our experience?
Yeah.
If I tell you. So yeah, he had a nerve conduction study. It was a complete nerve conduction study. And unfortunately, if the doctor who's doing the study is not thinking about LEMS, they will not necessarily do this particular procedure, okay? And I remember him very vividly because he was the first LEMS patient I ever saw at UCLA, okay? And it was I think it was my second year at UCLA. It's been like 8 or 9 years now since then. And I looked at the nerve conduction study, and I remember my trainee came back and said, I don't know how to interpret the study. I mean, it's clearly abnormal, but seems like it could be this, it could be that, it could be this, it could be that, and there, a list of 5 different things that were listed. But the one thing that the doctor who had originally done the study, and it was a reasonably well done study, it's just that the doctor who performed the study did not actually do the exercise test or the repetitive stimulation test, okay? And I looked at it and said, well, this could be LEMS. And then so we walked in the room and we did the exercise test, and that's when I said, he has LEMS. And then we sent off the antibody, right? Which was very difficult to get. I think it took a little.
Yeah, because they try a new kit to do the test in that specific time.
A new kit.
Yes, and it wasn't conclusive. They said no.
And they said, I think eventually we did it some right way and we got a positive test.
And then my primary doctors remember that, and he called you and asked you if it's okay to set it up. That's the one that confirmed that I have it.
Okay, any other questions? Yeah.
I'm just totally curious, do you ever see epilepsy in patients?
Well, there aren't that many LEMS patients for us to sample, but I have not actually seen patients with seizures, except for the ones that, no, I don't think I have, but it wouldn't surprise me, but if they had a seizure, but it's probably not directly related unless there's cancer like spread to the brain or something like that. Okay. Any other questions? All right. So we believe that this antibody against the PQ type voltage-gated calcium channel is what's causing it. It's present at the membrane, that presynaptic membrane. That's the part where I showed the upper part of that cartoon. Okay. So antibodies appear to inhibit synaptic vesicle release, so it prevents those little balls from being released into the neuromuscular junction. High frequency stimulation, repetitive activation of the synapse may result in a better response. So that's kind of the idea behind the exercise. There are also other antibodies. N-type voltage-gated calcium channels might play a role, and we think it might have something to do with autonomic dysfunction. There's also 15% of patients who don't have an antibody, and it's probably not because they don't have an antibody. It's because they probably have an antibody and we can't detect it. Either it's the same kind of antibody and our test is not very good or not good enough, or it's a different kind of antibody that we still have yet to discover. Because we have every reason to believe that these patients still have LEMS and still have LEMS through a very similar mechanism, through an antibody. Okay? And I believe the strongest evidence that suggests that antibodies might actually be causing LEMS in these patients is that if we take their serum, their blood, and we give them to mice, they also get LEMS. Okay? So there is something in that 15% that needs more research, and I'm sure we'll one day figure that out as well. Okay, but it probably does something very similar to the antibodies that you guys have. I think all of you guys probably have the antibodies that we know about. So possible explanations, I just said this, is that there are voltage-gated calcium channel antibodies that are just not detected by the test. And also it's possible that there are other antibodies that we don't know about that one day we will discover. Okay. So those of you who do not have cancer, as far as you know, need to be screened for cancer, okay, because this is pretty strongly associated with cancer. And we do recommend that, you know, a CT scan, PET scan looking for, it's most commonly associated with lung cancer. And I think Nicholas is kind of a rare exception.
Well, actually, sorry, they do the CT chest when I was in Urban.
Yeah.
But the problem was that they were upset to find out that I had myasthenia gravis through LEMS.
Yeah.
So they perform a biopsy, muscular biopsy too. So
Yeah.
they don't tell me nothing.
Yeah.
And they do the EMG, and the doctor send the reports May not.
Right. That's what the EMG report said, yeah.
I get upset with my neurology doctor at that time, and I say, May now, we were playing, or he's not sure, he doesn't know what he's got to do it.
Yeah.
Time goes by and I get sick, worse. No medicine, no nothing. No. So at that time, I got to get a second opinion, and I went to you.
And then we figured it out. Yeah.
Is it unusual, or is it more usual to be diagnosed with myasthenia gravis first in LEMS patient? Is that a normal pathway to a correct diagnosis?
I think it really depends. It varies. I don't see too many people diagnosed with myasthenia, but I guess it's possible that somebody might have thought of that. I mean, you know, that's his experience. Yeah. I think the patients, LEMS patients, look very different from myasthenia patients, and so most doctors would probably not be thinking of those two in the same patient. You know. If negative, so if there's never been a cancer that's been detected, and we don't know about a cancer, it should be rescreened, at least for the first 2 years. And we say at least yearly for the first 2 years. And after a couple of years, maybe there isn't cancer and you don't have to screen as frequently, maybe every couple of years, but still kind of be vigilant about it because we worry about it. So a couple of other sort of miscellaneous facts about LEMS. So 95% of patients with malignancy, LEMS is diagnosed before the malignancy, or the symptoms occur before the malignancy. So a lot of patients will say, I feel weak, and then later on we figure out that there is actually a cancer in those cases. So it's not unusual to find LEMS before the cancer. The cancer is probably there. It just hasn't been detected yet. Okay. So it's a pretty rare disease, 1 in 100,000, which if you work out and do the math, it's in the United States, that's about 3,000 patients. Okay, 1 new case for every million, and if you, and then this is global gene, so I decided just to throw in at least that there's a gene there. So 65% of patients with LEMS, at least the non-cancerous form of LEMS, actually have this particular type of HLA type, which is a way that the body has a way of declaring what kinds of proteins they were going to ask the immune system to pay attention to. Okay. So it's an immune system set of genes, for those of you who are not familiar with it. So a lot of autoimmune diseases say we pay attention to these HLA types. Okay. So a summary, It is an autoimmune disease. It's caused by antibodies, usually against voltage-gated calcium channel. There's a progression that usually starts in the legs, moving from proximal to distal, going to the upper extremity and eventually to the face. Autonomic symptoms that I talked about, dry eyes and constipation and those types of blood pressure issues are all part of that, and that's very common. Electrodiagnostic tests, this EMG nerve conduction study, are usually the way we diagnose our patients. Malignancy is found in about 60% of patients, and we of course have to be very careful if there is no cancer to keep looking for cancer. And LEMS progression is a little bit more rapid in the patients who have cancer than the ones who do not have any obvious case of cancer. That's my last slide. I can take some questions or discussion.
Does anybody have any additional questions regarding, why is this considered an immune disorder? Is it because of the antibodies?
Yeah. It's because there are antibodies, and the antibodies are causing the disease as far as we can tell.
Besides myasthenia gravis, are there any other autoimmune diseases that could lead to this LEMS diagnosis? That
You mean, are there other diagnoses
diagnosis
that
a
could
person-
mimic, could?
Well, that, like Nicholas was diagnosed with myasthenia gravis and then eventually was fine-tuned to be LEMS. Are there any other individuals who may have an autoimmune disease? What autoimmune disease would also maybe really be fine-tuned toward LEMS? Is there any?
Well, I think, I would tell you that there are a bunch of diseases that were written on the report that was sent to me for Nicholas.
Possibilities.
Yeah, there was motor neuropathy, there was myopathy, there was myasthenia gravis. I think that there were a lot of different things that were listed there. I think that it was clear to me that the doctor who saw Nicholas was thoroughly confused. Okay.
Okay.
With the sense with you, Patrick actually led me to share information. He was diagnosed with Guillain-Barré syndrome when he came to see me. And Miller fish are very so I have some suspicion during exam. When we checked his reflex one, it was no reflexes in the response. When I tapped him second time, it was very brisk reflex, which exactly Dr. Shieh just said. You need some warm up and have a good response. And I told him, let's go and repeat your EMG study because I don't feel that it was done right.
Mm-hmm.
Dr. Shieh, the patient mentioned lupus. Is that also like a route that they go through?
Yeah, they said it was lupus. Lupus is something that doctors say when they don't know what it is. It's just, if you ever watch House, there's this big quote, he says, it's not lupus, because everyone says, maybe it's lupus, right?
It could be lupus, Sjogren's.
Sjogren's, yeah. I can understand why they said Sjogren's, because you probably had some dry mouth, right?
Yeah.
Yes.
And then the doctor sent me to see the nose and throat and mouth specialist.
Mm-hmm.
I went to see the rheumatologist. And I went to see the acupuncturist too.
The acupuncturist, yeah.
Really?
Yeah, he saw a lot of doctors, yeah.
So the antibody that's attacking the receptor is the acetylcholine receptor, or is it like just specific to that receptor?
No, it's the voltage-gated potassium channel.
Oh,
Yeah. So we'll go back to that picture just so we're clear on that.
Yeah, just pressing it.
So yeah, these are the voltage-gated potassium channels right here. And these are the acetylcholine receptors. So these are on the muscle. So this is what we call postsynaptic because it's after the synapse. This is the area we call the presynaptic membrane. And so the neuromuscular junction, oftentimes we categorize diseases based on whether they're myasthenic diseases, whether they're presynaptic or postsynaptic. Myasthenia gravis are antibodies against these receptors, acetylcholine receptors. And so we call that a synaptic neuromuscular junction disorder. But LEMS is a presynaptic neuromuscular junction disorder where the antibodies are actually directed. Yeah. Yeah, Evangeline.
On those points, if I stimulate him like with acupressure, not acupuncture, but acupressure, would it, if they help, then kick in?
Stimulate your muscles
After a massage, and then you do an acupressure.
to kind of shake them off. I don't think that would help, but I mean the fact that if you start moving your muscles, it'll start
Because when I move
shaking.
these muscles, I go up and down, I get strength.
You get strength.
So I'm thinking if I'm pushing on something that has a block.
Yeah. Just activating your muscles will help. Yeah. But you know, obviously you just rest for a few minutes and you're back to square one again. You know. Yeah.
Because I know acupressure has
Yeah.
helped me.
Okay. Well, that's then you should continue acupressure. Yeah.
I mean, we
Yeah. Yeah.
we get to a higher level real fast, instead
Mhm.
of waiting around for strength.
So if you have more antibodies in terms of amount, is it more severe symptoms of?
Oh, if the titers are higher? I don't know how good the studies are in terms of the titers. A lot of autoimmune diseases, you'll see patients with really high titers who are mild, and you'll see patients with low titers and they're very severe. Myasthenia gravis is a great example. We don't really pay attention to how high the titers are because the number doesn't actually correlate with severity of the disease. I actually don't know if it's been studied in LEMS, if the number of antibodies in the blood is correlated in any way with severity of disease. I don't know that information. Hi, yes.
The patient organization, the autoimmune, the Dysautonomia International, said that sometimes they get patients who are diagnosed. So is that just another catch-all? Because then she said patients come to her and then all of a sudden they find out they have LEMS, after further diagnosis and all that.
I mean, it's interesting because dysautonomia is sometimes caused by another autoimmune disease with antibodies against a different channel, actually. Acetylcholine, ganglionic acetylcholine. We have a few of those patients. Yeah. Yeah. Is that it?
Great. Thank you so much.
Okay.